Hi everyone. It's been a while since we've kind of, interacted with each other. I think the last time we interacted either in a teaching session or a discussion session was when the NEET SS just happened, and then me and Aditya had come and talked about what we, felt the paper was like. By then we only had the stems of the questions, and it took quite a while to get to the options. Still, like, there are few questions where we like, obviously there are few questions which we never got, but I think usually whenever we do these recalls, the questions that don't come to us are the ones which are very simple, right? So very simple, nobody remembers because they would have, forgotten it the second they answered the question. So I don't think you need to worry a lot about those maybe 15, 20 questions out of the 150 that are left out. Rest of all of which we will be discussing in, multiple sessions, and obviously we'll upload them onto the app in one particular module, right? So focus on what we are discussing, because these are the questions that were dwelled upon by the students themselves and then they discuss them with us. So these are the questions that are important per se. When we talked about the initial, I did a session just around a month before the NEET SS, and I, gave the takeaways of how NEET SS 2022 was and 2023 was. So at that point, the general consensus or the general impression, the general discussion was the paper is tough. The paper is focused a lot on facts, on a lot on these gene type of questions, syndrome type of questions, uh, different disorders which are not very common. But this time it was much easier in a way, because it didn't, at least it didn't focus on the difficult, on the extreme type of questions. There are questions which are weird on numbers of dosages, at which side effects occur, etc., etc. But still, overall, the paper was much more conceptual, and also the paper was much more fundamental, in the sense they went breadth wise. Definitely they touched all the topics, yet they weren't the topics that were, not important per se. For example, if there was electrolytes, it would be from the what was taught, or what is usually taught in rounds, or whatever is usually studied at the basic level, right? So that is a good thing. But the bad thing obviously was the distribution was very weird. We discussed a lot upon that also that day. Peds cardio had disproportionately high number of questions. Peds onco is important, obviously it's a favorite one, but again it was a little bit too extra. And I think this was the breakdown that we had got. Neonate, obviously, it's always important, so that's not a weird one. Peds gastro, I think, was one area where usually we don't get so many questions. Then yeah, so peds onco, peds cardio were little bit of surprise. Rest, peds rheumat was there. Peds endo was less. Usually peds endo, peds neuro, they do have at least around 20%, 15 to 20% of the paper. This time it was not. Peds critical care was also very less, which we're going to discuss today. Infectious disease, I think infectious disease is something that they don't ask too much of a difficulty level in, even in the previous papers, and this time also they stuck to okay topics only. But again, it's so vast that it's a nightmare to study and nightmare to teach also, because at the end of the day it's very vast. But in the exam it's one of the simpler areas, right? So yeah, so Nelson has is always was and is the king. That's where the questions come from. Even in this time, there's almost no question that is not in Nelson, either conceptually or fact based. Somewhere or the other it is there in Nelson. And then videos is the guide. You will understand as we see through the discussion, as we see through the recall, you will understand why videos is, as the guide is what we took away even at that point, because we felt a lot of questions would be answered from the videos itself, right? We'll discuss on this after the recall, because then you yourself will kind of attest to that. Then MCQ Q bank practice, whatever are you reading from, Q bank is obviously important. Then recall topics were very important compared to direct repeat. So these were the cutoffs. So this is obviously out of 600. But what does this mean? What is 470? What is 415, etc., etc.? I'll come to it at the end, because again, that so the motto of this particular discussion is not to teach you what question was asked and focusing on that concept. That each concept will obviously take 20-30 minutes, and then we can't keep doing that, because that would take a lot of hours. That is a completely separate session, previous year topic based discussions. That is something which we might do as the exam approaches. So this is for people who are looking at the next NEET SS, or if somebody is seeing this video later, they'll see this video and understand what to read, right? So that is the only intention. My intention is to tell you that this was asked, not to teach that particular topic, right? So we'll go fast. Obviously my intention is only to tell you that this was asked, from where it was asked, and prospectively where you might read to get such questions right. That is the intention, right? So firstly, let's go to Peds Rheumat. 7 questions I think is okay. It's a small topic, but still 7 questions did come. This is it's not a straightforward question by any way. Also, just yeah, so it's not a straightforward question in any way. I think it's a little bit of a atypical question about atypical KD. So luckily we did discuss this. So in each question, I'll try to show you that it's not only Nelson that you can focus on, because if you have read Nelson through your MD, excellent, you have to double down on it. You don't actually need to go for extra resources except for your Q bank, right? Q bank is obviously always important for to practice MCQs, but apart from that, if your Nelson is very strong, then I would suggest you to double down on it and read Nelson again. But I know a lot of students who take a break after pediatrics, after your JR ship, do SR ship, and then decide. A lot of times you might not plan on doing a DM, later you might plan on doing DM. So in those cases you might little bit of your Nelson memory, exact that photographic memory that you have of the pages, at least that kind of gets fragmented. Or sometimes you may not have read Nelson, you might have read your PPTs of your class, or you might have read another textbook. In that particular case is where I think videos help a lot. And to attest to that, I'll be showing you that we have taught most of the questions that I've been asked, right? So atypical KD or incomplete KD is one and the same thing is what I had discussed, where you need at least 3 out of 6, and this includes albumin. This albumin level should be low. This includes CBC in the form of anemia, as well as thrombocytosis, and also it includes sterile pyuria, which is usually focused upon because that's one of the soft markers for KD in general. So all of these are there. I'm sorry, all of these 3 are there, but not serum ferritin, right? Then we have a very okay, this is not a very simple question. This is slightly tricky. This is just again asking what to what management to use for a mother of a neonatal lupus to prevent cardiac effects. So firstly, even if you know pharmacology, even if you don't know neonatal lupus, you don't even know lupus, if you just know pharmacology of your MBBS, you know that leflunomide is a teratogenic drug. And why would you give a teratogenic drug to a mother, right? So that is something antenatal, right? So that is something you can, I think it's a very common sense based question. But even if by chance you forgot that, which is very natural, so then we had discussed this. So these are multiple drugs. Again, none of them have very strong evidence except HCQ, which has shown in with good evidence that it prevents recurrence of neonatal heart block and cardiac effects of lupus. So HCQ is a very good drug, but apart from that, although there is usage of plasmapheresis in case reports with good results, there is usage of IVIG with good results, but these are not approved per se or strongly recommended per se. But yeah, corticosteroids is obviously recommended to stop progression of heart block. If already it's primary or secondary heart block, to stop progression, that is recommended. And yeah, we discussed beta 1 agonists also for augmentation of fetal heart rate. So all those were the other options. And leflunomide is teratogenic also, and anyway doesn't work in this particular scenario. So this was a very easy question. I'm not even sure if this was the question asked, because it seems so easy, especially with another congenital heart block. They're asking treatment, and here they're just giving you everything and then asking the diagnosis itself. So anyway, we have discussed this particular image, and I think this image was given, or it was just mentioned about the annular rash. I'm not sure about if it was an image based question or just it was described like this, but any which ways, in general it was a very simple question, so I don't think we need to discuss a lot here. This was slightly, maybe if you have not read, if your rheumatology is weak in general, then you might have missed, but otherwise I don't know, maybe you might have gotten confused with systemic sclerosis because there's Raynaud's etc there, but otherwise it's more or less if, unless your derma is also very weak, you would have got this correct, because nail pitting is a classic sign of psoriasis, and psoriasis is associated with arthritis, leading to psoriatic arthritis, right? So, and we have discussed this, you need 2 out of 3 changes: nail changes, finger changes, and family history out of the N, F, and FH. That's how you can remember it. So out of these 3, you need 2 out of 3 uh, to get a classification or a diagnosis of psoriatic arthritis. Nephrotic range proteinuria is seen in which, most commonly in which of the class of lupus nephritis? I think this is an overlap between rheumat and nephro. So obviously lupus nephritis is a overlap disease itself. So here it's obviously given in your Nelson, but we also discuss this in the Allied TND. So whenever we tell students that if you're kind of taking DocTutorials as your primary source, don't not just read just the main videos. Yes, main videos are good, but we sometimes notice that there are some things missing in the main videos, and we try to add them in Allied series. So we have 2 Allied series, that including, I think we have around 25 hours of Allied along with our main videos. So those are also important, because some small things like this, I think even if you wouldn't have read this specifically, most of you might have answered this, because this is something that we read right from our pathology days. Where we have membranous nephropathy, which is usually a nephrotic syndrome, while the class 3, class 4 is usually the nephritic syndrome. This is basic nephrology in your pediatric nephrology as well. So mostly would have got this correct, but still we have discussed this lupus nephritis classification, and we have discussed this, that what are the differences, class 5, class 4, what are the differences. Class 5, mainly it is the membrane, that leak that happens at the membrane level. It's not so much of an inflammation, it's just leak, and that leak is of protein, and that's why it's a high range proteinuria, high grade proteinuria, a nephrotic range proteinuria. It's given even more clearly, it's given even more discreetly in your Nelson, where class 5 directly it says significant proteinuria. So as you can see, obviously the question is definitely prepared from your Nelson, right? With less active lupus serology, again it's less of inflammation, more of leakage. Yeah, so this is something that we had. So this is again a very, very simple question. I think Peds rheumat was very simple this time, uh apart from, I think, yeah, one question which we'll come to. Apart from one question, I think most of which was very simple. Again, this is a classic image from your Nelson itself. I think same image came in the exam also, and that is of hinoxalurin purpura. The only confusion sometimes, just keep in mind, because again this time they've asked you this image, next time they might give you the same or a very similar image, but they might give you an infant, and they might show the image will have more of edema, more of hemorrhage. That would be infantile hemorrhagic edema, right? So that also you just keep in mind. Obviously, we've discussed this. This is something that uh, is a very, very important topic, very common topic. I think every elite, every QRP, every mini test, every grand test, HSP question, I always put from Peds rheumat side, because it's a very important topic, right? Most common vasculitis. So yeah, so I think this was the main videos, and this was the elite which we discussed. So this is something that, to be honest, we didn't discuss. Neither I discussed in rheumat per se, nor did Aditya discuss in while treatment of nephrotic syndrome. Actually, this was given a nephrotic syndrome treatment, but I think cyclo, obviously being a rheumat drug, I would take some responsibility as well. So I don't think this is an easy question, unless I again, it depends. If somebody has read Nelson very well, and it's in the chapter of nephrotic syndrome, which is obviously maybe the most important chapter in your in your systemic pediatrics. So that way, if you see, yeah, it is not very missable. But again, it's not a fact that is easy to remember. 250 mg per kg, after that azoospermia starts. It's not even something that is very practically seen, right? It's not. When do you know azoospermia happens? It's not pediatrics, right? Azoospermia is there in a patient when he's 25, 30 years old. So it's not exactly even a pediatrics question. But yeah, it's given in Nelson, it's given quite discreetly in Nelson, and is given in a very important chapter. So I won't blame them too much for giving this question. But yeah, it was a tough question. Next, we'll go to infectious disease. I think there were 8 questions or something approximately. Yeah. So again, this is one of my favorite topics, because this is asked repeatedly in your INISS. Now, again, we always tell you there is overlap, especially in general peds, there is always overlap between INISS and your NEET SS. So whenever somebody asks PYQs, I tell them go through all the PYQs discussion that we have done in the app, because although there is a lot of mix between the INISS PYQs and the NEET SS PYQs, all PYQs are general pediatrics PYQs only, and we have seen so much overlap between INISS and general NEET SSP general peds. So there's so much overlap, and I don't think you should try to see only NEET SS PYQ for NEET SS and all. So whatever I think we have, I just checked them today. I think there were 10-12 PYQ sessions that we have in our app, and I think they are very important because, as you can see, Coxsackie A is not something that is a very commonly seen disease. It's even if you look at your, I mean, if you go through your textbook, you might not want to stop there and read about Coxsackie. You might think that, okay, this is not very common, I'll just skip it. But as you can see, it's a very commonly asked repeat question, right? So hand, foot, and mouth disease was what was given, and I'm not sure if the image of the boy was given or not. Again, I'm not. I didn't get whether the image was given or the description only was given. But yeah, we've discussed this multiple times. We've even discussed a very similar, case-based scenario also. Yeah, herpangina versus herpetic gingival stomatitis, herpangina by Coxsackie and gingival stomatitis by herpes simplex. This is also again not very difficult. I would say the only maybe confusion, I'm not sure if this was itraconazole. If it was itraconazole, then it's a good MCQ, because then they're basically confusing you between your aspergilloma versus an invasive aspergillosis versus ABP, etc. But I think they gave directly halocyle, and serum galactomannan is also positive, so that makes it a little bit more easier. That is, it is invasive aspergillosis, and invasive aspergillosis, your first line treatment would be voriconazole, right? So invasive, I think it's more or less a straightforward question, especially with them directly giving halo sign and them directly giving your galactomannan positivity. Yeah, so we discussed the how fungal ball looks as well as how your halo sign looks, and ABP obviously we discussed in the pulmonology part. Lemire syndrome, this was something that we discussed I told you the session that we did, NEET SS 2022-2023 session that we did just 1 month before the 2024 paper. That I think, like I was talking to, we had a podcast, as you could see, there also, like I think 2-3 questions came from that 1 hour session, right? So that is the level of repeats that keep going on. That is something that we ignore a lot. Yes, concepts are important, that forms your basis of your entire preparation, but repeats are something that you should not miss. Repeats take you back from those difficult questions which someone else might get just by looking or just by reading repeat questions, right? So repeats you have to do. Concept is your platform, but repeats are your, like roads which can help you take you to your goal, right? So Lemire syndrome is basically IJV thrombosis after an infection of your fusobacterium, as simple as that, right? So NEET SS 2023 was asked, NEET SS 2024, same question gets repeated, right? So fusobacterium, you should remember, fusobacterium, IJV thrombosis, and as well as septic embolism possibility. That's it. Yeah, so these are your differential diagnosis, and this was the question that was asked last time, and I think, yeah, this time it was, the question was not same. This time they asked what is Lemire syndrome. Last time they gave what is Lemire syndrome and asked what is the diagnosis. This time they, gave Lemire's in the stem itself and gave the descriptions in the options. Yeah, so neurocysticercosis, I think we've discussed. I have also discussed this, and Divya has also discussed this. I have discussed this in parasitology, and Divya has discussed this. Is very simple. I think this was one question where options, they could have confused you, but they did not. They could have confused, saying just carbamazepine initially, then they could have said steroids first, followed by antiparasitic drugs, or cysticidal drugs followed by steroids. All of this they could have given, but I don't think they gave those options. They kept it very simple. So always start steroids before. You have to suppress any possible inflammation that can happen when those cysts burst out, right? So first you should start steroids, and then obviously antiepileptics is first, because you have to control the seizure. After that, between steroids and antiparasitic, always start steroids first, and then start the antiparasitic drug. Yeah, so albendazole or albendazole and praziquantel, and obviously you will start your anti-epileptic drugs as well because they're seizures, right? Yeah, I think there was one more pick where obviously Divya has taken an entire session on neurocysticercosis. I think I also wanted to put that picture where she discussed in detail about when to start steroids, how to start your cysticidal drugs, etc. Also, it's been discussed, right? So this was a direct repeat. I think along with that NEET SS 2022-2023 session, I also shared a PPT of your 2019 and 2020 questions. We didn't do the discussion, but I shared the entire PDF on the group 2019-2020, and this was a direct repeat, exact words: mild conjunctivitis, signs of pneumonia, and gram stain of conjunctival discharge shows no organism. So this is not something I made now. This is something that was what was there with me since March or something. We had arranged this whole NEET SS 1920 questions from sources, and then we had shared this. So this is a direct repeat. Again, who knows these? If somebody wants it, I can share it again in the group, or somebody can ping me also to get this particular PDF. So it's a direct question from 19 or 20. I'm not sure, but that particular time it's a direct repeat. This is also, I think, something where we discussed in the QRP. Obviously, we didn't do a complete, module on Yersinia, but yeah, we discussed this as a isolated MCQ because pseudoappendicitis is something that is a common quiz question and a common trivia question kind of thing. So I think we put this in one of the I put this in one of the PYQ sessions. I couldn't click a pic of me teaching that particular video. I was not able to, get, but this was what I could get from my laptop, which was one of the previous PPT. So this was one of the PYQ sessions. You could find it in one of the PYQ sessions. So which mimics acute appendicitis. So as you can see again, INSS. So this is an INSS repeat coming, INSS general pediatrics repeat coming into your NEET SS. So this happens a lot. So go through all the PYQs, whether you're preparing for your INSS, whether you're preparing for NEET SS. If you're preparing for your INSS, more so because you're anyway reading most of the time your specialty. For your general peds, focus on your gem topics, which are basically your repeat topics. So it's even more important for your INSS, right? Yeah, so I think this was from the NCC one. Why do you use steroids to? Because inflammation, which happens when the cysts burst, that can worsen all this. So to reduce that, you use steroids. So yeah, I think I'll take the blame a little bit because this enteric fever we have discussed in QRPs, we have discussed in the videos, but we didn't discuss this particular cardiogenic shock. So this particular, I think I'll definitely put out an updated video on enteric fever because this is something, complications of enteric fever, I think is now important because you know they've gone on and asked about the management also. We did discuss about the complications, what all can happen, what can happen in the abdomen, perforation can happen, what can happen generally sepsis can happen, cardiogenic shock can happen. We discussed all of that, but they went one step ahead and asked the management where you have to add dexamethasone. So in addition to antimicrobial, supportive treatment and appropriate supportive treatment and empirical treatment is there, but additional treatment with DEXA is recommended, especially when severely ill in the sense of your shock, obtundation, stupor, etc. Because obviously that will help in increasing your intravascular strength, right? Then you have Plasmodium vivax malaria. I think malaria video is just removed a few days back, so I couldn't get the exact image of that. But we have the mini test. So mini test is the third thing apart from elites and our main videos. Mini test is something that, as you can ask any of the previous year toppers that are there, I think almost everybody has given the mini test. They might not have seen the videos, might not have done the entire Q bank, but mini test was something that was given by everyone. So there we have almost an exact question, or at least the same topic basically, which is basically from this particular Nelson table or Nelson flowchart of the management of malaria. So here basically there Plasmodium vivax is there and danger signs are there, or complicated malaria is there, and what is the management is being asked, right? So firstly you have a blood smear that is positive, and then you have malaria is there, severe malaria is there, complicated malaria is there, and that complicated malaria, you will directly go to IV artesunate, right? So that was the question there. So that was infectious disease. I think it's always a challenge to complete infectious disease in totality, especially when they do have fungi, viro. I think that was one area where I tried to focus more on, because that is something usually ignored in our preparation of our final MD. So I did do sessions on parasito, mycology, even antifungal drugs, because that is asked both in INSS, NEET SS. Then I did a decent amount of content on virology as well. Bacteriology, I agree, enteric fever we missed out on, but I'll put out an updated video soon. Right. So PEDS critical care, I think it was little bit tough, not very straightforward. Directly opening itself, first question was a little bit tough. So we did discuss airway obstruction. If you go to ventilation, we did discuss lung mechanics, how the various pressure act, right? So we even discussed this particular mnemonic that if the obstruction is extra or extra thoracic, then there is inspiratory collapse. Yeah, so extra thoracic, whenever there is an obstruction, there is inspiratory collapse, because it's coming from outside the thoracic cavity, that is above thoracic inlet, like larynx, pharynx, upper trachea, etc. And there, whenever there is inspiration, then usually the negative intrathoracic pressure is what pulls the air inside, right? But this also causes a drop in the pressure in the upper extra thoracic, that is outside the thoracic inlet. It causes a drop in the pressure. If there is an obstruction or a weakness, then airway collapse will occur at that site. As simple as that, right? So when extra thoracic airway obstruction is there, the airway will collapse, because there is a negative pressure or a drop in pressure there. Whenever there is obstruction, then above the obstruction site there will be pressure, there will be collapse due to this negative pressure. During expiration, positive intrathoracic pressure is what usually pushes the air out, and extrathoracic airways, that is outside the thoracic inlet, which are there, they are less likely to collapse and they will tend to stay open. So during expiration they will stay open. When inspiration, because there is no pressure, because there is negative pressure, in fact, they will tend to collapse, right? So collapse occurs above the level of obstruction, and that too during inspiration. So this is what we discussed. Obviously we just didn't discuss the exact things. We discussed a little bit of conceptually how the pressures move, what is extrathoracic pressure, intrathoracic pressure at each level. That is what we discussed in that particular area, right? Yeah, so this one was so we discussed foreign body in multiple aspects. So I did one session on respiratory foreign bodies, that are foreign bodies that go and lodge in the trachea, or they might go downwards into the respiratory cavity. That was one session that I did. And another session was on GI foreign bodies. So GI foreign bodies, again, I divided it into benign foreign bodies, something like a coin, then there are button batteries, and then there are sharps, right? So this was one of the easiest question. If they wanted to ask, obviously they're not, then obviously this was not a INSS PEDS gastro paper, so I would expect it to be at this level only. But this was a very simple question. Coin comes, we discussed multiple case scenarios, if you remember. So coin comes directly gone into stomach, what do you want? You can wait, right? But another important option of starting laxatives was given. So I think this was little bit tricky, because if you look at the NASBGAN guidelines that we discussed, the first thing that is said is consider straining stools or giving laxatives. So that was the first thing. If not, repeat X-ray. No endoscopy needed is obviously there. So endoscopy immediately and all these things you remove. This was the main confusion, and clearly NASBGAN guidelines say, which we discussed, say to consider laxatives. Yes, you can wait and watch a bit, you can repeat X-ray 2 weeks, etc. But when somebody directly gives you to consider laxatives, that will be the better answer. It's not always given. Practically, if you look at it, many times it's patient is asked to wait and watch for a week or two. But yes, if laxative option is there, that is the best option. So again, this was one of the easier ones. The only thing I hope nobody did was getting first line, first tire confused. So first tire is, again, it's not very much demarcated clearly in your Nelson, in your flowchart of Nelson. But in many of our Indian critical pediatric critical care books, and even in your, I think even in your Rogers, there is division of first tier management options, second tier management options that come after your general measures, right? So general measures is what is your first line. So here they have not used the word first tier or step one or anything like that. They've just said first line, which is a very generic term. So when they've said first line, there's no doubt about it. This was one question that there was a discussion with one of the students. So there's no doubt that when they are saying first line, it is clearly a generic term, and that is what is your mild head end elevation of 30 degrees, as simple as that. So maintaining stabilizing the ABC, maintaining temperature, glucose, all of this, and also your other things like giving your anti-epileptics, treating coagulopathy. Basically, stabilizing is what is your first line thing. Beginning nutrition, etc., etc., is your first line. I think this is something that neither of us discussed. I again kind of clearly agree that again this was in the same unit, same chapter, this chapter, right? So I would say now that this chapter is important, so we'll definitely go back to the drawing board and do one more session on this, maybe upgrade the session in terms of depth, because obviously who would think that they will ask, this is a very much, and again, an adult emergency kind of question. This is not something that is very common, because in children we don't see such classic x-rays. It's a lot of times the skull is very malleable, and such classic x-rays don't come about, right? But okay, now they've asked, so I think this particular chapter seems to be a lot more important. So this was ADH. So this was given in the same this thing. So whenever it's like a lens, it is SDH. Whenever it is biconcave, if it's like a, I don't know, lens, like this is a biconvex lens and this is a concave or convex lens, but this is something which is like a moon or something, sickle or something, then it is SDH. If it is like a biconcave shape, then it is epidural hemorrhage. So this is something that we obviously you would have read in your internship for your PG entrance. It's a very common question. SH, how does it look on CT? EDH, how does it look? SDH, how does it look? If you remembered it, great. That would have helped you. But I understand many times we don't, so it might have been a little bit difficult. I think this was one of the easier questions. Again, I think the catch here, if you could have gotten it, is hyperglycemia. So hyperglycemia is there, then tachypnea, vomiting, altered sensorium. I think that is, again, tachypnea is one very good clue here. Vomiting, altered sensorium, more or less generic, because a drug has been ingested. But respiratory alkalosis, so respiratory alkalosis drugs are not very common. Aspirin is one of the aspirin also, it's early aspirin injection. So I maybe even yeah, so child immediately presents, kind of maybe a scenario like that is given, because it's early aspirin that causes a respiratory alkalosis. Slowly it becomes a mixed respiratory alkalosis is there, and along with that a high anion metabolic acidosis also develops, because at the end of the day aspirin is a salicylic acid, right? So it's directly ingested, so it causes a hagma. Initially it's only respiratory alkalosis, and and why does that occur? Because of your tachypnea. So it's a very good question. I think it's a little bit easy question only, but yeah. So we obviously discussed this in acid base we discussed metabolic alkalosis, and here we've discussed aspirin also in high anion metabolic acidosis. I think this is more or less a simple question. I think we discussed when does, yeah, so superimposed metabolic alkalosis. Yeah, we discussed aspirin in, I think, poisoning also we discussed aspirin, where we discussed it at the place of hyperglycemia. If you go to the general poisoning approach to general poisoning, there we have what particular biochemical abnormality will be associated with what particular poison. So there you have hyperglycemia, which is given here, and hyperglycemia is associated with aspirin. So that is also there, right? So that is also another clue that is important, and we did discuss that. Venturi mask. So again, oxygen delivery devices I've put 2 times in our group. So if you can, I'm not sure if you're able to see, this was 19 March and this is 1st March to 2024. So there also I took, this is a tough topic, and that was when we were, discussing ventilation a little bit more on the group. So Venturi mask, this is the particular, this is the slide that I've been putting. So it's a very good one pager of various oxygen delivery devices, where you have Venturi mask, you have simple face mask, partial rebreather, non-rebreather, etc. Where it's not very, bulky. It's just a one pager by Dr. Nick Mark. A lot of nice ICU one pages are there. So here obviously it's 2 to 5 liter per minute. Yeah, so 2 to 5 liter per minute and 24 to 60%, right? So that was what was the question. A very easy question. If you've gone through this particular image, I think, yeah, so somebody asked also, I think this was posted in response to, yeah, so somebody had asked to post the particular image. So I had posted this, and we've posted that before as well. So yeah, shock we have discussed in the QRP session, but again, it's not a very simple question, this one, because they've given early septic versus late septic. So early septic is where you have decreased PCWP, right? So early septic versus late septic, what happens is in your early, it is pure vasodilation. But when it comes to your late septic, it's like the entire body has become septic, including your heart. So there your cardiogenic shock also starts. So if you look at cardiogenic shock, there is obviously increased PCWP because your blood pools up, goes back pressure happens, and your pulmonary vein also increases in pressure, right? Because of your cardiogenic shock. So PCWP increases. And in your early septic, it's pure vasodilation. So your preload has gone down. There's no blood coming into your lungs. So your pulmonary vein has gone dry. So early septic decrease PCWP, in cardiogenic increase. So in late septic, it is these both combined, right? So you have almost normalization of your PCWP. That is what happens in your late septic, and hence late septic capillary wedge pressure decreased is really not right. So this also I have posted in the group. I think this was what we discussed in the QRP. Here I don't think we have discussed this much, that early versus late, what is happening. But I'm not sure if we discussed sepsis in great detail. All the surviving sepsis guidelines we discussed. I'm not sure if we discussed this there, but yeah, this is more or less conceptual. This is the Nelson one. Even if you look at it here, they've not differentiated it clearly, early sepsis or late sepsis. So yeah, I would say this is a little bit of a difficult question, but this is something, if you actually, we've read through our internship, etc., right? So in most of our conceptual teaching, it has been taught there, right? Early septic versus late septic. So this is a very controversial question. Not at all clear what the answer is, because they're basically asking posterior urethral valve is being operated, means it's become relieved, right? So it's become open. So whatever obstruction was there, whatever post renal AKI was there, that has been relieved, right? So this is what they're asking. So post obstructive scenario, what is the most common electrolyte abnormality? That is the question here, especially in the context of PUV. But actually, if you look at it, there is hypernatremia that occurs, there is hypokalemia that occurs, because there's post-obstructive diuresis that occurs. When post-obstructive diuresis occurs, potassium gets thrown out, water gets thrown out much more in comparison to sodium most of the time. So hypernatremia, hyponatremia both can occur, but most of the time the water is that one that gets flushed out more. So hypernatremia, hypokalemia are, so we've discussed this in our, obviously we've discussed in hyper also, we've discussed this in hypo also, where we have post obstructive diuresis. But if you go to Nelson, if you go to nephrology, pediatric nephrology, if you go to PUV, clearly it says that after the child is relieved of posterior urethral valve obstruction, the main thing that you should be wary is of dehydration, and you have to be careful and be prepared of giving IV rehydration. What does that mean? What is sodium abnormality, right? Sodium abnormality is water abnormality in actuality. That means water has gone. That means hypernatremia. So I also discussed this with pediatric nephrologist, pediatric intensivists. So most of the consensus was both of these occur, but maybe hypernatremia is a better answer, was their consensus. But after seeing Nelson, I'm very more confident that the question was framed only in the context of hypernatremia only. So either it was given a grace mark or it was marked as hypernatremia. So anyway, you just remember that now what you should take away is that these electrolytemias are important, and especially the etiologies are important. Etiologies we have discussed in great detail. Each dyselectrolytemia we have discussed in great detail. Right. So coming to cutoff, so 2,500 applicants were there, which has increased by, I think, 40% or something. I think last time it was 1,700 or something. So compared to previous, 40% of 1,700 is around 800. So that much has added on, right? So it's obviously the competition is increasing, but if you look at the cutoff, you're more or less. So these are the questions, right? So these are out of 150, how many should you get correct, assuming everybody is answering 150, which is recommended. So everybody is answering 150, how much should you get correct? So I would assume almost everybody would be targeting or thinking more or less top 20, right? So I think you get almost all branches in your top 20, around top 20, top 10. Even if you look at the question number difference, almost very less, right? So 120, 125 is the question difference between top 5 and top 20, right? So you have to get 120 out of 150. That means you have an option or a margin for error of 1 out of 5. So you need to get 4 out of 5. And we obviously discussed these many questions. I think we discussed more than 20 questions. I think there were hardly 2 or 3 questions that were missing from what our sources, right? From our mini tests, our group, and elite, not even, yeah, so elite TND and our main videos, right? So this is essentially pretty much 200 hour content or something, not very huge. And I think if you have your Nelson strong, then that's okay, then revise that and just do your MCQs. But if your Nelson you feel it's not strong, then definitely use the videos and add Nelson to it. So one saying that we usually say is, if you're in your residency, if somebody's in residency, don't keep videos as your main source. Nelson should be your main source. Your only intention should be to complete Nelson as well as possible. But if you're post residency, if you're preparing and you have to target that exam, you can't, your aim is obviously not to master Nelson, right? So that can, even if you want to do it, you can do it in your SS as well. Firstly, you have to get into SS if you're giving it for getting it right. So then I would suggest, if your Nelson is very strong, double down on it. If not, use the videos, add Nelson to it, and add MCQs to it, right? So that is the takeaway from this particular uh, I think whatever recall we have done. I'll come back in a few days. We'll do the next recall. I think we'll divide this because we really want to do it in a complete thorough manner. We want to do the entire 135 at least questions, I think, which we have. So we'll kind of do it in multiple sessions and combine it into one module. Like we already have that P/Q module, we'll add on a separate module of NEET SS 2024 recalls, right? Yeah, we'll meet in a few days with, I think, cardiology, because cardiology is something that was asked quite a lot. We'll do that. And I think PEDS endo, also a few questions were there. So this is something that we'll do in the next session.
Recording stopped.